Perfect. Great. Thank you so much for being here. As you're becoming more familiar with research, you're going to hear Institutional Review Board. You're going to hear human protection more and more. I think one of the most important parts when it comes to human protection with regards to research is the Institutional Review Board at each institution. We've had wonderful cooperation and assistance through our IRB, as it's known in short, and we're very fortunate today to have Ms. Karen Allen, who's the Director for Research Protection and also helps us work with the Institutional Review Board, and she's going to provide us lots of information as it comes to research protections and human protections at UCI. So thank you for being here, and we'll go ahead and get started. As mentioned, then we'll go to your midterm after that. Thank you, Ms. Allen, for coming.
So thank you for inviting me here. I have my iPhone, and I have the time set for 50 minutes so I don't go over, because I know midterms are important, okay? All right, so, okay. How do I work this? Just press up and down? Sorry.
The way you can work it is actually, that's a really good question. That's my fault. Is just either down arrow or right arrow.
That I understand.
Yeah.
Okay. All right. So as I was introduced, my name is Karen Allen. I'm the Director of Research Protections here at UCI. Research Protections is under the Office of Research. I report to the Vice Chancellor of Research. In my responsibilities as Director of Research Protections, I work directly with the Institutional Review Board, which is concerned with human subjects protections. I also work with our IACUC, which is our Animal Care and Use Committee in regards to research with animals, and our Stem Cell Committee. We have a Stem Cell Oversight Committee, both in the context of utilizing stem cells in vitro and in vivo with animals and with humans. But what we're going to touch upon today is really human research protections and the Institutional Review Board. So what are my objectives for this discussion? Well, number one, I want to sort of broaden the discussion initially and talk about what is human research protections, realizing that the IRB is one component of that program. Two, I want to touch upon Institutional Review Board. Now, I know in your readings you had a whole chapter that went into the IRB and what the IRB does, and I'm not going to drill too far down into that, but I do want to highlight some of the important components. What is human research protections? What is human subjects research? Obviously, there are important definitions that are necessary that you know, and so we're going to touch upon those. The basic ethical principles in the context of human research protections. What does the IRB do? What do they look at when they're sitting around this large table in this very cold room, to be honest with you, talking about research projects? So we're going to talk a little bit about the criteria for approval, the levels of review, and then lastly, I want to talk about the informed consent process and a little bit about HIPAA research authorization, because as you go out there and you're actually conducting research, there may be opportunities that you're involved in the informed consent process, and you want to make sure that you know what you're doing. Because I can tell you from our perspective of going out and working with investigators and doing what we call quality improvement reviews, and sometimes monitoring for compliance issues, time and time again, informed consent and HIPAA authorization are the primary problems that we see. So if we can do what we can to educate investigators and future investigators how best to document this important process, then I feel like we've done our job, okay? So, what is a human research protections program? Well, I want to say that I've been in this Office of Research since about 2000. And the concept, the term human research protections program wasn't even known at that time. That the research infrastructure has become more and more complex over the years, to the point now we have multiple entities that are part of this program. The IRB just being one component of that program. The other components being my office, which is research protections, in the context of my staff supporting the Institutional Review Board. We have compliance and oversight, as I talked about, doing our quality improvement reviews, as well as going out and doing compliance audits. We have the investigators and the researchers who we are responsible to educate in regards to the protection of human subjects. We have other committees. So people look at the IRB as the gold standard committee, but they don't realize that we interact with lots of other committees as well in regards to research. We have a conflict of interest committee, which looks at the conflicts of the research team and whether that can in some way influence the results of the study. We have a radiation safety committee. So if the research involves radiation, then guess what? The research also has to go through that process as well. We have stem cell committee, as I mentioned earlier. So if in fact the research involves stem cells, maybe they're collecting specimens because they want to induce pluripotence, then that has to go through that committee as well. So human research protections, the IRB being a component of that, is a very broad, complex infrastructure that makes it very difficult for investigators to sort of navigate. And so what I really see my role is to try to facilitate the process for the investigator. Yes, we're here to protect human subjects, but we always want to make sure that the research can go forward, assuming that it meets the criteria for approval.
Can I ask a couple of questions? In the previous slide, there was an acronym HIPAA.
I'm sorry?
On the previous slide, there was an acronym HIPAA. So it wasn't spelled out in the slide. I just want to make sure that it's not as different category.
So HIPAA is the Health Information Portability and Accountability Act, and maybe I have the acronym wrong. Right, so that's protected health information, and we're going to talk about that. And I'll get the acronym right. I never can remember that acronym.
And my second question.
Yes.
If you don't mind. Why does stem cell get its own special category? Is it because certain stem cell research is not allowable under federal guidelines? Or, I mean, what's so special about it compared to some other cloning, for example?
So why does stem cells get its own specific committee?
Yeah.
I think originally we were talking about embryonic stem cells. That's really where the science started, is using embryos because of the pluripotency of embryos. We've now transitioned from using embryos to more often inducing pluripotency using skin cells or adipose tissue. And so I think originally it was from an ethical perspective, and because use of embryos was such a hot button that we had a specific committee that wanted to address those issues. Now, as we transfer more, as I said, into more induced pluripotency, I think you're going to see HESCRO over the years migrate back to either part of the animal program or part of the human program. And there's actually been discussions on the campus. We're just not quite ready to do that. But we do see that happening, again, as a way to facilitate for investigators, so it's one less committee that they have to try to navigate. So let's talk a little bit about the IRB. In your readings, you probably realize that the IRB has to have a certain composition. It has to have at least 5 members. They have to be varied in gender, so we have a mix of female and male. They have to be varied in experience as well as their profession. So we have Ph.D.s, nurses, MDs, PsyDs, all a different variety of individuals that come together to review human subjects research. They have to be sensitive to the issues. They have to be knowledgeable, so we have to have the appropriate expertise at the table. They have to be aware of the regulations and our institutional policies and procedures. And when I talk about institutional policies and procedures, it's not just simply UCI, it's UC. Okay, so UC has lots of policies that we need to know, and then from there we sometimes also impose additional procedures. The purpose of the IRB is simply to assure that the rights and the welfare of those individuals that are volunteering to participate in research are protected. That's simple as that. That's their whole role. The IRB is not here to protect the institution, although many people argue that we are. We are really here to make sure that human research protections is in place for the subject and that we try to facilitate the research. Ultimately, the IRB is a required component, that if you're doing research that involves an investigational device or an approved drug, you're going to have to fall under FDA regulations, and FDA regulations calls for IRB review. If you're doing a study that is supported by NIH or NSF, they require institutional review. So it's an entity that's necessary at this institution. At UCI, we have 4 committees. 2 of them are dedicated to what I call biomedical or clinical research. 1 is dedicated to social behavioral research. And 1 of them, which is our new committee, is specifically formed for looking at compliance issues. And it's actually made up of members from the other 3 committees. We have over 40 members. And again, as I mentioned, it's made up of the breadth of individuals. We have MDs, PhDs, nurses. We have to have community membership. We have to have individuals who are not affiliated with the institution, as well as individuals who are. We have to have somebody who's considered a non-scientist, somebody who doesn't really work in the scientific realm, as well as we have, obviously, multiple scientists around the table.
Question? The non-scientists, do they have to have some other background related to the research so that they can be knowledgeable, or are they just anyone off the street?
Well, there's 2 thoughts on that. Sometimes it's maybe a legal person, so somebody with a JD background who can maybe look at it from a legalistic perspective. What we here do at UCI is we tend to have individuals who are what we call community representatives. So they may have been a previous subject on a research study, so they understand the research from a different context. We utilize the community members primarily to look at whether they would want to be involved in the research, whether they understand the research. We have them finely tuned to look at the consent form. And we say, if you were participating, would you understand this form? And so they're very good at helping us sort of work that informed consent process. So let's talk about some definitions. In order to constitute human subjects research, you need to meet 2 definitions. One is research, and of course, that's the federal definition of research. It's a systematic investigation, including research development, such as pilot studies, testing and evaluation, that's designed to develop or contribute to generalizable knowledge. So there's 2 components to that definition. One is you have to have a plan, and 2, you have to have intent to contribute to generalizable knowledge. It's not that I'm going to publish this paper if the results come out the way I expect them to. It's that I have intent to do so. I'm trying to contribute to the scholarly knowledge of whatever topic you're working in. Second definition, human subject. So you can be doing research, but it may not necessarily be human subjects research, which therefore wouldn't fall within the IRB's purview. Okay? Situation where you're doing research. Maybe you're looking at what we call decedent data. Well, you'll see from this definition here, human subject is a living individual about whom you're collecting information. You're collecting information either through interacting with them or intervening with them, or from maybe accessing their school records or their medical records where you have identifiable information about them. Okay? But if I'm looking at decedent information, it's research maybe, but it wouldn't necessarily constitute human subjects research, wouldn't need to go through the IRB. Another example, if I'm looking at student evaluations. So at the end of this class, you may have to complete a student evaluation. They may be collecting information about you, but they have no intent to contribute that knowledge. They're going to use that knowledge really to improve the class, right? You're going to give them some feedback about what you liked, what you didn't like, how maybe the midterm exam was too hard, right? But ultimately, there's no intent to contribute to generalizable knowledge. They're going to use it here specifically for internal purposes, so it wouldn't qualify as research. Student projects. Oftentimes, as you go through your methodology class, they're going to ask you to design a project. And you may have to go out and collect some minimal data, analyze it, and then present it back. In the context of the classroom, that doesn't qualify as research. That really qualifies as an educational activity. Wouldn't require IRB review. Now, let's say you came up with a good idea, you analyzed some limited data, and you really liked the results, and you think, wow, Europe is coming up. I want to expand this project, get Europe funding to do the project. So now you're starting to think about doing research. And here at UCI, if you're going to Europe to get funding and you ultimately get funding to conduct the research, you're going to need approval through the IRB, because now we see it as research. If you're using human subjects, obviously if you're interacting or accessing identifiable information, you're going to need to go through the IRB, because we do see that as human subjects research.
If you were to alter the data and remove all identifiable private information, you wouldn't need to go through the IRB?
So, good question. So if you were going to alter the data, and so it had identifiers originally, and then you were to strip it, because you had identifiers originally, it would be considered human subjects research. However, if you were doing secondary analysis of an anonymous data set, it's already been stripped before you ever got it, not human subjects research. In addition to definitions from the Office of Human Research Protections, I want to talk about the definition from the Food and Drug Administration. So the Office for Human Research Protections looks just at that, human research protections. The Food and Drug Administration looks at those materials that are under their purview: food, drugs, medical devices, radiological devices, some cosmetics if they're making claims about health, okay? They have a different definition. They're not so much focused on human subjects protections in that context. They're really focused on clinical investigations. So their definition of the clinical investigation is an experiment that involves a test article, and the test articles are exactly what I just talked about: drugs, devices, either investigational or approved, where you're conducting an experiment, and where you intend to either try to get marketing approval or you intend to change the labeling of something that's already approved. So you now want to expand the use of that product, you want to change the labeling, you want to extend its use, you're going to need to come to the IRB if you're doing an experiment. And it involves a human subject. Their definition of human subjects is a little bit different. Recipient of a test article or a control subject, and either a healthy human or a patient. Questions about the definitions? So what this does for the IRB and for the investigator as well is you have to follow, if you're doing a clinical investigation, you're automatically doing human subjects research, so you have to follow two sets of regulations. Now the nice thing about it is they're basically the same. The only difference is that on the Office of Human Research Protection side, we can actually waive the requirement to obtain informed consent, or we can waive the requirement to obtain a signed informed consent. On the FDA side, we cannot waive informed consent. We can maybe waive a signature, but we can't waive informed consent. If you're doing a clinical investigation under FDA regulations, you have to have an informed consent process.
What's an example of a type of study that you could do without having, or that you could waive informed consent?
How about your example earlier that it was identifiable data set? So maybe you were going into the medical records. You weren't interacting or intervening. You were just accessing identifiable information with the intent to only collect de-identified information. So even though you see all of the identifiers, you have no interest in those. You're simply wanting to collect and extract specific information that wouldn't qualify as identifiable. In that instance, oftentimes the IRB will allow you to waive informed consent altogether. And it wouldn't fall under the FDA regulations because it wouldn't constitute a clinical investigation.
One more question. So many years ago, I was involved in a proposal to analyze human bones that were donated, I guess, for them. These were old bones. And it turns out they were from Native American places. And we didn't think it was human subjects, not living people. We can't really even tell who they were. But somehow it became controversial because of the community consent to do this.
Right.
I wonder what the IRB has.
Right. So you were analyzing existing bones. Obviously no identifier, so it wouldn't necessarily constitute human subjects research. However, the fact that you got those bones from what would be considered maybe a sacred burial ground, obviously then there's all sorts of cultural factors that are involved. And sensitivity to communities and cultures, I think that was the concern. Again, it wasn't so much an IRB issue. I think it was probably an overall research issue. And I think at the time, probably that's, if Office of Research did get involved, that would have been the reason. Yeah. So I have a couple really simplistic examples here. So let's just go through them. So number one, investigator X wants to do a study where cadavers will be run through an X-ray machine to scan for healed fractures. No information about the cadavers or their living relatives is required. Is this human subjects research? How many say yes? How many say no? No. Individuals are deceased, and in addition to that, we're not exactly sure at this point in time what they're doing, but if they were doing research, wouldn't be human subjects research. Next one. Here, a physician wants to test whether Tylenol or Advil is more effective at controlling headaches. Plans to do a within-subjects design where subjects will be prescribed Tylenol or Advil during sequential headaches, then analyze the patient's results. Both drugs are already approved by the FDA to treat headaches and are available over the counter. Is this human subjects research? How many say yes? How many say no? Yes. Actually, it is. Now, again, here we don't really know so much about intent, but they're talking about wanting to do a study. So yes, even though they're both approved, they're ultimately doing a study where they are engaging human subjects, collecting data with intent to contribute to generalizable knowledge. So would constitute human subjects review, would require IRB approval. So I want to talk a little bit about the basic ethical principles in regards to human subjects protections. And in order to do that, I want to show you just sort of a timeline of how we got to that point. And I know that Dr. Golub is going to come in a few weeks and talk to you more about the ethics, and with the ethics, the history. So he told me specifically, Karen, don't talk about that. So I'm not going to. So what I really want to talk about is the Belmont Report and the principles embedded within the Belmont Report and how they translate into what we're doing today. But in order to do that, I need to talk to you a little bit about the National Commission for the Protection of Human Subjects that was put in place back in 1974 and was really convened through 1978. So the National Commission of Protection for Human Subjects really came about because of the Tuskegee syphilis study. And how many of you know about the Tuskegee study? Probably many of you have heard about it in public health or in maybe psychology class. So the Tuskegee syphilis study went on for 40 years. And it wasn't until 1972 that it really sort of came to the limelight, and it was through an expose in the Washington Post. And what had been going on is the intent of the research, which was being done by the Public Health Services, which is now the CDC, was basically to study the etiology of syphilis prior to penicillin coming about. And so they basically enrolled these individuals in what was ultimately research without appropriate informed consent, and then monitored them for 40 years. And it was so important to them to continue to monitor these individuals that ultimately, when penicillin came about, they didn't offer it to those individuals because, again, they wanted to continue to study the etiology. Obviously, when that expose came out in 1972, there was a big uproar with the congressional hearings, and the National Commission was put in place at that point in time. Their charge was to develop ethical principles in regards to human subjects protections, and that ultimately is what the Belmont Report represents. So the Belmont Report has 3 basic principles that we utilize today. For every IRB meeting, we basically talk about those principles in some fashion. The first one being respect for persons, or what your mother would say is be respectful. Okay? When we talk about respect for persons, we're talking about giving individuals the autonomy to make a choice of whether they choose to participate or choose not to participate in the research. In the Tuskegee syphilis study, these individuals weren't even aware that this was research. So therefore, they really didn't provide appropriate informed consent. In addition to individuals having autonomy, we recognize that there are certain individuals who have limited autonomy that need additional protections. And our regulations speak to 3 groups, although there are many more: pregnant women and the unborn fetus, prisoners, and children. Now, the Commission actually went much further and talked about individuals who may have economic disadvantage, such as those individuals in the Tuskegee study, individuals who may have mental incapacity, But the regulations speak to those three groups, and those are what we call the vulnerable protections. So children, pregnant women, and prisoners. So in addition to respect for persons, where voluntariness is important, there's also beneficence, or be nice. That when you look at research, you want to make sure that you maximize the benefits, whether it's the benefits to the individual or the benefits to society. And you want to make sure that you minimize the harm. And then justice, the be fair principle. You want to make sure that there is an equitable distribution of the risks and the benefits. Don't enroll a subject population because they happen to be a convenient sample, for example, prisoners, when those prisoners will not ultimately benefit from the research. Okay? So think about those three principles when I talk about what the IRB looks at. And what I've shown you here is just sort of a snapshot of our checklist. So when the IRB reviews a specific protocol, they actually have a very long checklist. Sometimes it's up to 15 pages that they have to go through and consider when they're actually reviewing that research. And this is just an example. So this specifically talks about the risk-benefit assessment. And again, things I just discussed. Are the risks to the subjects minimized by using procedures which are consistent with sound methodology? Are we using procedures that are already going to be used for standard of care? If the study calls for a lumbar puncture and you're already doing a lumbar puncture for medical care, don't do another lumbar puncture. Just do an additional draw. Minimize the risk, also minimize the pain. Right? So the IRB looks at that in the context of, if we're doing something already for standard of care, can we do it, can we just get an additional amount for research? With full informed consent that that's what we're doing, but is there a way that we can minimize the harm, minimize the risk? Subject selection, talking about the justice principle. Is this subject population appropriate? Based upon the research, based upon the aims of the study. Are we minimizing undue influence and coercion? So oftentimes, faculty members want to do research on their students, right? Because you're learning, you have certain knowledge that maybe other students don't have. The IRB is concerned about that because of two reasons. One is we don't want you to feel unduly pressured to participate because your instructor is asking you to participate in research, because it may be, well, if my instructor says, ask me to participate in research and I say no, maybe they're going to know that and I'm not going to get as good of a grade, or they're going to think of me unfairly. So you may feel that intense pressure to participate. From the instructor's side, we're concerned about compromised objectivity. If they find out that you said no, are they going to feel a little bit different about you? So we're always concerned in the context of putting in an intermediary such that somebody else comes and talks to you about the research, and the instructor doesn't see those who participated and who chose not to participate until after grades are already dispersed. So that's a situation of undue influence, right? We want to make sure that if, in fact, you choose to participate, it's truly voluntary, and you don't feel that you're being unduly influenced to do so. Also, compensation is another way of unduly influencing somebody to participate. That the compensation is so high that the individual is willing to take on this additional risk that the individual would not normally take on had it not been for that compensation. And sometimes that happens in psychiatry studies, not so much in cancer studies where there's a potential for benefit, but sometimes we see it in psychiatry studies where, it's an investigational drug, and the company, we have to have a certain amount of consistency in making sure that they meet their visits, so they try to provide some level of compensation so that they would make sure that they come into their regular visits. And we always have to balance what procedures are involved in the research and what amount of compensation the student may be receiving. Again, to make sure that we're not unduly influencing, the subject will be receiving. We don't want to unduly influence those individuals for participation from a compensation standpoint. And then general subject protections. We're concerned about privacy of the individual, how we're protecting their identifiable information, as well as about how we're maybe conducting informed consent. If it's a sensitive study, we want to make sure we're not conducting informed consent out in the hallway where everybody can hear what's going on, but rather we're doing it in a private location. And confidentiality. the data itself. So once somebody agrees to participate, what are we doing with that data? We want to make sure that it's protected. And more we're hearing about confidentiality and realizing that if it falls into what we're going to talk about in a minute, which is protected health information, there are consequences, financial consequences for breaches of confidentiality. And sometimes it's in the millions of dollars. So levels of review. We have 3 levels of review. Actually, we have 4, but I'll touch upon that in a minute. We have exempt, expedited, and full committee. Before I talk about the levels of review, I want to talk to you about minimal risk. So minimal risk is a specific definition in the regulations. And when you talk about minimal risk, you're looking at both the probability of the risk, so the likelihood that it's going to occur, as well as the magnitude of the risk, the actual harm itself. And we want to make sure that it's not greater in and of itself than those things that are normally encountered in daily life or during the performance of a routine physical or psychological examination. And the regulations really say not greater in and of themselves than those normally encountered in daily life, without putting it into context. Whose daily life? And so UCI went above and beyond and said in the daily lives of a general healthy population. And the reason we went with more of an absolute definition as opposed to a relative definition is because if you're talking about a cancer patient who normally receives CT scans as part of their standard of care, and we use a relative definition, then we're likely to categorize that activity as minimal risk for that cancer patient, but yet when it happens in a healthy subject, we're going to categorize that as greater than minimal risk. And so we're putting the cancer patient actually at greater risk than we would the healthy participant. That's what's called a relative definition. And so we wanted to go with an absolute. So our absolute definition is in the daily lives of the general healthy population. So when we talk, yes?
Sorry, this might bring us back a little bit, but as far as compensation goes, are individual IRBs responsible for defining what an adequate amount of compensation is? I know for like our school, like Experimetrics or whatever, they only give you like half a credit of extra credit for every like 30 minutes or something like that.
Right.
Who decides that? Is it the institution?
So that's a great question. So in the case of UCI, the social sciences set that criteria. And whenever they make policy procedures, it always comes to the IRB for consideration. And so then we work with them. The IRB doesn't actually make the determination, but if the IRB has concerns, we would address it with the social science, or I think cognitive science actually runs that pool. But in general, the investigator sets it, and then the IRB considers it in the context of undue influence and coercion. So the level of risk. So essentially, the level of risk is determines the level of review. So something that is exempt is pretty minimal risk if risky at all. Something that's expedited would meet our minimal risk definition that we just discussed. And something that's full board review means that it's greater than minimal risk. And really, it's who reviews it. So exempt research, my staff basically just confirmed that it meets the criteria for exempt research. Expedited, it goes to a subcommittee, an IRB member, and subcommittee can be one person. Full board, it gets the full board review, and sometimes it's as many as 10 to 15 people that are looking at that one specific study to make sure that it meets the criteria for approval. Oops. So exempt research. Again, when we talk about exempt, it's exempt from the federal regulations. So it doesn't have to meet the standards of the federal regulations. Again, IRB staff confirm it. If once in a while we may get an IRB member involved if we don't know if it's really exempt. There's 6 specific categories. Verbal consent or no consent is often appropriate. No consent if there's no interaction. Verbal consent if there's interaction. In my examples here are research involving survey procedures with adults or research in an educational setting involving normal educational practices. Expedited. Again, no more than minimal risk. There are specific categories reviewed by a subcommittee. Documentation of informed consent can be waived. So again, now I'm talking about waivers, and that's regulatory requirement. And generally, continuing review is annual. But I can say that we are in the process of providing extended IRB approval, which is a new concept, but we're providing extended IRB approval for certain projects that don't have federal oversight and qualify as minimal risk. So that's going to be a big benefit to investigators who are doing minimal risk research. Examples, research involving interview procedures and collection of biospecimens, let's say a blood draw or saliva sample. Non-invasive medical procedures wouldn't involve radiation, and then focus groups. And then full committee. Anything above expedited is automatically full committee. Signed consent is almost always required. Those do require to come back annually, and I've given you examples here of a clinical research study with an investigational drug, research involving radiation, interviews about illegal behavior, and then possibly a longitudinal study involving a vulnerable subject population. So these are the statistics at UCI for last year, and you could see that there are the 4 categories of review, and I've broken it down into social, behavioral, and biomedical. The first category is what I call administrative registration, or IRB authorization agreements. More and more IRBs are collaborating. As opposed to multiple IRBs reviewing the same study, we are collaborating and really relying on one IRB to do that particular review. And so that's what this administrative registration speaks to. So we have 20 biomedical projects that involve a collaboration with another IRB, and so far 14 social and behavioral projects. And this is where we're relying on another IRB, not where they're relying on us. You can also see the differences between social, behavioral, and biomedical. So if you look at full board, greater than minimal risk studies, we only have 2 on the social behavioral side. We have 305 on the clinical biomedical side, which speaks to, obviously, the level of risk involved in the research. Most of things that go through our social behavioral committee are exempt or expedited level of review. Those 2 projects there involve a vulnerable subject population being prisoners. So overall, we have about a little over 2,100 studies here at UCI. And to support those studies, investigators have submitted a little over 3,200 transactions, changes to the study, applications for annual approval, or actual applications themselves, new applications. So overall, our office last year saw about 3,000 transactions for these studies.
And just to be sure, the exempt category, investigators cannot designate that by themselves.
That is correct. Yeah. So exempt research, again, it's virtually no risk at all. It still requires that somebody make a determination, not the investigator that actually qualifies for exempt. So here at this institution, the institution has designated the HRP staff or the IRB staff to make that designation. Yes. And we've made it much simpler. It's a lot easier now than it used to be. But yes, at this time, there are some schools that allow the departments to do that. But that's, we haven't moved that far yet.
So if there's 1,100 total studies in the biomedical clinical and 2,000 were submitted for transaction or for review, does that mean like roughly 1,000 of the studies did not pass IRB approval? Oh,
no, that's a good question. No, actually, we have 1,148 active studies, and there were 2,283 transactions. Those transactions could be a new application, it could be a modification to a continuing application, or it could be the annual review cycle that has to go through.
Oh, so if all of those were to renew it annually, you would see that the transaction submitted would be another.
Right, we count it as a transaction, yes. As far as disapprovals go, we do disapprove protocols, but it's rare, and it's only after we've met with the investigator, the IRB's looked at it 2 or 3 times, and we still feel it doesn't meet the criteria for approval, they will disapprove it. The interesting thing is if the IRB disapproves it, the institution cannot allow the research to go forward. However, if the IRB approves the study, the institution can still make a determination that they choose not to have that research go forward. Okay.
Quick question. So for an exempt study, let's say it's like a survey, but you're doing it with a vulnerable population, like prisoners or pregnant women, is it still considered exempt?
So exempt research, if you're doing it with pregnant women, it's allowable. If you're doing it with prisoners, no. The regulations don't allow prisoners to be used for exempt research. Yes. Okay, so informed consent. Well, what is informed consent? It's really the individual's voluntary agreement to participate in the research. The document or the form or the dialogue allows an investigator, allows the individual to understand the research and to knowledgeably and voluntarily participate. I'm not going to go through these, but these are the requirements in regards to informed consent. There's two components. One is basic elements that have to be in a consent process, and the other one is additional elements. So the basic elements in general have to be involved in a consent process unless the IRB waives that requirement. Otherwise, you'd have to talk about the purpose of the research, the procedures involved, what are the risks, what are the benefits. Okay? So this is a little bit about the process. You meet with the individual, you make sure it's in an appropriate place to have a reasonable dialogue. Sometimes, depending on the level of risk involved, if it's a clinical investigation, maybe for a cancer trial, the individual's obviously going to bring in loved ones, or they may bring in friends to help them sort of understand the process. If they don't bring those individuals in, they may often want to take the consent from home and think about it. They're not going to make a decision necessarily on a risky, greater than minimal risk study right there. If it's an exempt study or it's an expedited study, the informed consent process may take 5 minutes, 10 minutes, 15 minutes. If it's a greater than minimal risk study, oftentimes it's going to take much longer. So the individual reads the consent form, you go through the consent form with the individual, you allow them to ask questions, you answer those questions. If they go home, they come back with more questions, you answer those questions as well. Once the individual decides to participate, you make sure you get documentation. And this is a step that people always make mistakes on. You want to make sure that the subject signs and dates the consent form, him or herself. Then the individual obtaining the consent sign and dates the form. And then if a witness is necessary, and oftentimes it's not, but if it is, under these situations where you're using what we call a short form process, or the individual can't read or write, you need to have a witness present. And the witness can't be a relative and can't be somebody who's on the research study. It has to be somebody who's outside of that realm. So sometimes you have to grab a nurse or somebody else, but you want them to sort of witness that this is truly a voluntary process. And then this is just really to point out that the informed consent process never ends. If we're talking about a longitudinal study, there are going to be those changes that we talked about. And sometimes those changes are adding on additional procedures. Sometimes there's additional risks or a reduction in the benefit of the research. If that happens, the IRB is going to require that you reconsent these individuals and allow them to make a determination based upon the knowledge that you've provided whether they want to continue participation in the research. So last discussion item is HIPAA. So HIPAA is Health Insurance Portability and Accountability Act. All right? Essentially, it protects patients from inappropriate disclosure of their personal information. This personal information has been gathered in the context of medical care. And we call these identifiers protected health information, or you'll see also maybe personal health information. And these are all of the variables that qualify as protected health information. So name, address, phone number, medical record number, health plan ID number, social security number, anything that may be in your medical record that qualifies as these identifiers is protected. And if you want to access or collect that information as part of your research, you're going to either A, need to get authorization from the patient, or B, need to get a waiver from the privacy board. And here at UCI and at many other institutions, the IRB has dual hats. We're the IRB, where we're protecting human subjects, and we're also the privacy board in the context of HIPAA, where if an investigator wants to utilize a waiver because they're not interacting with subjects, but they are going to be seeing protected health information, or they want to collect a portion of that protected health information, then the IRB can grant the waiver. So we're going to either require a signature or we're going to grant some sort of waiver. So that's how the IRB is involved in protected health information. In the context of you as a researcher, if you're obtaining informed consent and HIPAA authorization is required, you're going to be getting informed consent, signature on one document, and HIPAA authorization on another document. Because here at UCI and at all of the other UC campuses, they're two separate forms. So if your research calls for both, you need to make sure you have both documents. The IRB has what we call a document depot that you can log into. If you're registered as a research personnel on that project, you go to this secure website, you use your UCI ID, you log in, and you can pull down the latest consent form, and you can also pull down the HIPAA research authorization form it's required. So if for some reason you don't have them or you're not sure that you need them, I would go to the document depot. Verify it, print it out, use it. Okay. So, in summary, we talked about the complexity of the Human Research Protections Program, and the IRB is a component of that. We talked about the purpose and composition of the IRB. Definitions, human subjects research, clinical investigation, the basic ethical principles, beneficence, respect for persons, justice, how that translates into the criteria for IRB approval and the levels of review, and a little bit about the informed consent form and HIPAA authorization. Now, I apologize, this is a whirlwind. I've actually taught a course on the IRB, believe it or not, for 8 hours, 2 4-hour sessions. So this is just a snippet, an introduction, probably more than you really wanted to know. Nonetheless, if you have questions, I'm happy to answer them. Thank you.